So I would really like to thank AIOS and the scientific committee for giving me this opportunity and having this wonderful lineup of talks of in and around dry eye disease. So my talk would be really, like the image says, the devil really lies in the detail. It's not very unusual for us to miss dryness in these patients, especially the ones with milder and subclinical forms. And this becomes much more relevant when it comes to cataract surgery. So why are we talking about cataract and dry eyes in particular? It's because in a hostile environment like it is in dry eyes, even a very routinely performed surgery like cataract can actually have uh, can be challenging and have suboptimal outcomes and give us surprises. And there's lots of studies which show in literature that there is significant undiagnosed dry eyes in patients who present to our routine cataract surgery clinics, which goes missed and could correlate to the refractive surprises and unhappy patients post-surgery. Apart from that, the phacoemulsification itself has been reported to reduce tear film breakup time, tear meniscus height, and corneal sensitivity, and also with associated increase in ocular surface staining. While in most cataract patients, this may happen, but it's transient and recovers, this becomes important in those patients who are actually lying on the borderline with subclinical or milder forms of the disease, where addition of medications, inflammation further worsens the consequences and gives us bad results. So in this setting, I would like to discuss two cases today. First one is cataract surgery wherein an underlying dry eye disease was missed. And my second case would be a patient with existing diagnosed dry eye disease and you want to plan a cataract surgery in such a patient. So my first patient was a 63-year-old lady who presented to our clinic with discomfort, burning, pricking sensation associated with blurry vision or more so discomfort while viewing for 6 weeks following cataract surgery. So she came to us because she was unhappy and referred by the primary physician because the inflammation was not going down and he suspected dry eyes. And she did not have any other comorbidities or did not report anything significant. But when we looked at it, it was a well done cataract surgery. But as you can see, even beyond 6 weeks, there is significant inflammation. There are clogged meibomian orifices. There's mild fading of the luster of the cornea. And actually, the tear meniscus height looked a little on the lower side. And the ocular surface staining actually revealed a lot of SPKs and now had filaments all around. And the patient, though had 20/20 parts post-surgery, was actually unhappy because of the photophobia and the associated symptoms. And when we did a Schirmer's 1, that is without anesthesia, her Schirmer's was 5 and 3 mm at the end of 5 minutes, and tear film breakup time was also 4 seconds. We went ahead and did a more detailed dry eye examination, but before that, the other eye also showed some SPKs, but the disease was not as severe as in the operated eye, probably because of confounding additional factors of the surgery itself. So when we did additional dry diagnostics, so she clearly had very significant dysfunction, reduced lipid layer thickness, and also reduced tear meniscus height. So she had a mixed type of dry eye disease that is component of both aqueous deficiency and evaporative. So we went ahead, did an autoimmune workup. She came out positive for RA factor and anti-CCP. We started her on topical steroids, lubricants, and cyclosporin. Along with a rheumatologist, she was initiated on immunosuppressive therapy. Following that, she was better in terms of her symptoms, and she was much more comfortable, but was unhappy that the diagnosis was made after surgery. So probably would have preferred to have been diagnosed to have dry eye before she was taken up for cataract surgery. So there are various things that this patient could have actually landed up with a lot of refractive surprise because biometry is not always very reliable in these patients, and also could have had other complications if the dry eye was much more severe. The most important thing is that, or interesting, I should say, is that the patient knew she had some form of arthritis. She was on Ayurvedic medications for some time, few years ago, and then she obviously will not find it relevant to mention it to a doctor who's going to operate her eye, but we tend to miss out a lot of patients because they don't communicate either. So a quick brief of the second case. This is another case who was a 58-year-old lady who presented to us with complaints of mucoid discharge, pain, redness, and watering. and diminished vision for about a month. She had similar such episodes in the past. She was a known case of rheumatoid arthritis who was on treatment prior but had discontinued because she could not tolerate the immunosuppressive. So at presentation, as you can see, the right and left eye had severely inflamed surface, significant mucoid discharge. In the right eye, she actually had hypopyon with epithelial defect and uh, stromal infiltrates, and she was very miserable. The patient was actually brought on wheelchair because she could not open her eyes. And we sent for scrapings and the conjunctival swabs, and it had turned out to be Staph aureus, which was multi-drug resistant, but it responded reasonably well to medical therapy. And then she was also initiated on systemic immunosuppressive therapy along with topical steroids based on sensitivity. And she recovered well at the end of 6 weeks. But then she wanted to undergo a surgery, that is cataract surgery in her left eye, because right eye had already undergone it in the past. So now the question is, when do we take up these patients for surgery? So we wanted the ocular surface to stabilize further on. So waited for 2 to 3 months, continued her on immunosuppressive therapy, and gave her topical medication. So as you can see, the left eye was well controlled, and then it did reasonably well after a cataract surgery. We put the IOL implantation after her biometry became somewhat stable. That is, we repeated multiple readings, and when they were kind of correlating, that's when we decided we'd go ahead and put that IOL power. And then we stepped up her immunosuppression in periocular period, and then continued to do her dry eye management. So as you can see in the images below also, when we optimize the surface with good steroid therapy and lubricants and systemic immunosuppression wherever required, the surface becomes much better, more stable, the visibility increases, the biometry becomes more predictable, patient comfort and the results also get better. So it is very important to optimize the surface in all these patients. Towards the other extreme end, where we have these really severe cases of dry eye associated with cicatrizing conjunctivitis, like the ones with OCP here, also tend to do reasonably well with a cataract surgery when we give them PROS lenses. And over a period of time, when we continue to keep them on low potent steroids and immunosuppression, the surface actually gets much better. And here the portion was excised a little during surgery, and an AMG was placed, which is the reason the cornea appears much more clearer. And then with clearer lenses, we can actually rehabilitate these patients without a lot of risk to a large extent. So all in all, I would like to say that when patients present to our clinic for a cataract surgery, I think it's very important to look for certain signs. That is, examine the lid for meibomian gland dysfunction, look for a lot of debris if it's collecting. It should have otherwise been cleared from the eye, but maybe because of low tear production, it is not being cleared. Look for SPKs and look for loss of sheen of cornea. And once that's there, it's very important for us to do tear film breakup time. And if in doubt, you could always assess the lacrimal gland secretions by placing a fluorescein strip over the palpebral lobe of the lacrimal gland, and look for the number of look for the quantity and the number of ducts that are giving away the tears. Then you would know whether you're dealing with dryness or not, or is there a component of aqueous deficiency or not, and then you can take them up for surgery. So in a nutshell, it is very important to look for subclinical dry eye disease in all patients presenting for cataract surgery, especially if we're considering premium IOLs. And we should not forget to examine the meibomian glands. And preoperatively, optimization of the ocular surface is really required if any deviations are noted on preliminary examinations. And then it's best to plan surgery after stabilization of biometry, especially in patients with dry eye. That is, take multiple readings, and when the deviation is not too much, that's when you think, and when the SPKs are cleared and the surface appears stable, that's when I think you should go ahead and do the surgery. And then it's very important to perioperatively and postoperatively manage the patient in terms of immunosuppression and topical lubricants, stepping up steroids for alleviating the symptoms of dry eyes. Thank you.
Thank you very much, Pragya. And I think our discussants, Dr. Maipal sir, has not joined us yet, and Dr. Harvansh had to leave. So could we have quick comments from Quresh sir and Dr. Samar Basak, if you are there?
Yeah, that was a Pragnya. That was a good presentation of cataract surgery, and unfortunately, most cataract surgeons put the patient on slit lamp, bypass all layers till they reach the cataract, just see whether somebody has removed it in the past. If not, then it's a mature cataract and to be removed. So the front portions are generally not seen on a cataract surgeon slit lamp, unfortunately. So the question of staining and looking for the lacrimal gland, that incidentally, I also very recently started doing Pragnya after webinars. And it's a very elegant way of checking the ducts coming from the lacrimal gland. And it adds one more thing to armamentarium, because none of your SBM machines or all those diagnostic machines have this. And it's such a simple, elegant test which you can do in even a rural setup. So it's nice to know a patient has dry eye prior to cataract surgery. And I also agree, I use a lot of immunosuppressives in patients. There's many patients who are not diagnosed preoperatively with rheumatoid and other collagen disorders who end up with really bad post-op eating your head after uneventful surgery. So again, an excellent presentation and a lot of take-home messages for cataract surgeons.
Thank you, sir. Maipal sir, you've just joined. Maipal sir, are you there?
Yeah.
So Pragya just told us about two cases excellently demonstrated, and the protocol of a cataract surgery. Where does the dry eye protocol or the dry eye testing fit in, sir? In your hospitals, what would you do before a cataract surgery? Would you do a dry eye assessment, or is it done only for selective cases?
So, frankly, Partha, I think the focus on dry eye has increased over the last couple of years. And even though I had personally worked on the myopography way back in 89-90 in Georgetown University, where the myopography was described, I really, the impact of dry eye really was really not felt to that extent as is being felt now, and with the new treatment modalities that are coming in. Dry eye evaluation for us is a mandatory thing for pre-LASIK workup, but it's still not mandatory for cataract surgery as things stand today. But I think there is no harm in taking this as a this thing, because we just started 4 or 5 years ago a pre-cataract workup package that includes a specular microscopy, an OCT, and an IOL master. So that is something that has become, because we have been stung by a couple of patients who had some unpicked or undiagnosed macular pathology like an ERM or something like that, which was not diagnosed. And the patient was very, very unhappy as regards the outcome. So therefore, we are doing the OCT, but not so far the dry eye protocol. But I think as things are going to happen and as the premium intraocular lenses are coming in, that is going to become more and more important, because the patients are dysfunctional, and the common thing they say is radak pad rahi hai, we are not happy, etc., etc. They have no problem with the vision, but then they are very, very unhappy, and that continues for long. So obviously they had a pre-existing dry eye, because we are dealing with the geriatric age group, and as in the geriatric age group, and especially post-menopausal women, the chances of having a dry eye are much higher. So I would say strongly, because in India we are dealing much with numbers, but I think in the Western countries, the dry eye evaluation has become in a lot of places a standard of care that is there, and the OSA, etc., they give reasonably good information. One important thing is that whenever you are doing in cataract surgery a biometry, the patient should not be having a dry eye, because that can give refractive error kind of a IOL power calculation, and you should pre-treat that person for dry eye before actually doing the IOL master. And the other thing is that the cornea should not have been touched with an applanation or had a paracaine or a xylocaine, etc., instilled before doing the IOL master. So these are a couple of things that is there, but just to answer your question, it is still not a standard of care. The only thing is, because we charge separate for OSA, that is, and it's still not available on the centers. Shermer's is gaining ground, but LASIK, yes, standard of care.
Partha, if I could intervene here.
Yes,
In our place, we are doing Shermer's and mammography, But is it that you would do a fluorescein test to look at the aqueous tear deficiency in all your cataract patients, Pragya?
No, I think for me, the thing that works out best whenever I'm seeing any patient is I try and look at the tear meniscus height. How does it look in our normal patients to kind of have a reticule kind of a thing in the head so that I know that this is where the normal should belong. So as I found it very useful as I keep using it in normal patients, and when I see that the tear meniscus height doesn't look really good to me, or there is some debris collection that is unusual, or the cornea doesn't look as glossy as it should, or the adjacent conjunctiva, then I go in and then do a Schirmer's one first before putting in any drops. And then I would do a surface staining to confirm the dryness. But sometimes it happens that the patient actually complains of dryness. We do the Schirmer's, it looks good. We can optimal gland secretions, have a look normal, then probably looking at more of an evaporative component, probably the tear film is actually breaking up faster and stuff like that. So either which ways, I found that with the number of premium IOLs that are increasing, I think having a dialogue with the patient is very important preoperatively, that if there is dry eye disease and this is good and this is not good for you, because most often patients are not very happy having the diagnosis after surgery. So I think it's too much to ask for a complete detailed surface staining examination for every cataract patient. For me, the easiest way is to try and have a look at unstained tear meniscus height. It may be difficult in the beginning, but definitely works over a period of time. We'll be able to pick up that we can actually try and correlate it with Schirmer's, and then you will know, no, this Schirmer should be somewhere around 10. I think so, something like that.
So actually, we are reaching on a very important question. In a busy clinic for a cataract practitioner, should he institute a dry eye protocol, and should he have his optometrist or his technicians do the dry eye, the Schirmer's, the T-BUT, and the tear meniscus staining by them to get a feedback? Because for cataract surgeons doing all this, plus what Pragya said, that judging the cornea by its glossiness, that comes from experience of a cornea surgeon mainly. So should we institute it or should we not? And let's look at, Maipal sir has already said, Chitra has already said, let's ask Rishi Mohan, would you have in all your cataract patients a dry eye protocol?
Thanks, Partha. I think it's a very good question, and it never used to exist. But again, as Mahipal rightly said, over the last few years, the importance of dry eye has picked up so much that it has become imperative now to check these patients. Premium IOLs, of course, it's a standard of care. I agree with the clinical approach wherein you need to be a little choosy as to which patient you will do a dry eye assessment and which eye you won't. But these patients often have, along with the low tear meniscus height, an element of a lid parallel conjunctival fold at that age group. So there's an element of conjunctivochalasis which will throw off any assessment. Clinical or even any of these machines which are looking at TMH are not going to give you an accuracy when there is a small conjunctival fold or a little bit of chalasis. So that's important. Anybody with more than a 0.75 cylinder in my practice coming up on K readings is going to get a dry eye assessment, and they will have to get repeated on more than one technology to try and assess the accuracy of the cylindrical component as well as the axis. So for premium IOLs, which includes toric monofocals, yes, it's the standard of care now. For monofocals, not as much. So there it's a bit more of choice, wherein we look at it clinically and then take a call.
Okay. Naren, at your hospital, what is the standard of care?
Yeah, thank you, sir. So basically, I think like sir said, I think we also follow the same, clinically we observe. And if there's any signs of, even from complaints to any signs of any kind of dry eyes, be it MGD or anything, then immediately they go through a complete screen tool. But for premium IOLs, we do, definitely, there's no doubt about it. And I mean, what other thing is normally I personally do, even in refractive and cataract, is even in normal patients, even if they don't have dry eyes, I start about 2 or 3 days before the steroids which I'm giving post-operatively. So that what it does is, whatever little about, if at all a patient has some amount of slight inflammation in the eyes, it'll just make it, much lesser, cooler, cool the eye and make it much more quieter. And then we go ahead with the surgery. The patients do much, much better. I truly believe that there is a tipping point for dry eyes. So if it goes beyond that inflammation, that's when, you have a very long term of dry eyes, and it's very difficult to handle those patients.
Okay, so for all patients of cataract surgery, you start off the steroid 3 days prior to that?
Yes, yes, sir. Even refractive, whatever the steroid I'm giving post-operatively, I start 2 or 3 days before and then continue. I mean, as per the, quickly taper after the surgery. So this, I found it much, much better. The number of complaints of, even though we assess and then everything is fine, no dry eyes, we do the surgery. Sometimes we have those set of patients who develop dry eyes. I feel these are the set of patients who have a slight amount of inflammation in the eye, and it gets tipped off after the surgery, and then we have a long-term thing. But this small thing, it made a lot of difference.